I'm just going to give 1 more minute and then we'll get started. Okay, I think we'll get started. More people will likely come in over the next couple of minutes. We've got about 100 registered for the event, so more will probably join as we go. But we'll get started because it is 12 o'clock. So thank you all very, very much for joining our lunchtime session today. We're going to be looking at the carbon footprint of end-of-life care. Just so everybody on the call knows, sorry, I'm just letting people in as they come. This is being recorded, so it's just to make you aware that the session is being recorded today. And if I could ask, when you're not speaking, that you have you're on mute so that we don't have any feedback or anything while people are speaking. We'll be using the chat function for anyone who wants to ask any questions or comments or get any discussion going. Please do use the chat function as we go. So the session today has been prompted by work on the Lancet Commission on the Value of Death, which was published in January this year. And it argued for a radical rethink of death and dying that shifts the focus away from prolonging life at all costs through multiple medical interventions at the end of life to one that places more emphasis on the value of people and relationships and looking at that relationship that we have with death and dying. As well as that, at the UK Health Alliance and climate change, one of the areas that we focus on is reducing the carbon footprint of healthcare. And end-of-life care is potentially a very big component of that, and that's what we're going to hear about today. So welcome to our wonderful panelists. We've got a really good group of panelists lined up for what is a very, very fascinating subject, I think. So we've Richard Smith, the co-chair of, or the chair of the UK Health Alliance and Climate Change, and also co-chair of the Lancet Commission on the Value of Death. Max Watson, who's the ECHO Programme Director from Hospice UK, and Jane Blaseby, Professor of Surgery at the University of Bristol. The format for the session today is each of our panelists is going to speak for about 15 to 20 minutes. And then after that, we'll have some time for questions and answers. So like I say, please do use the chat function as we go through the talks, and then we'll revert to that at the end of the session to pick up any questions and discussion that's been happening during the session. So I am going to hand over, first of all, to Richard Smith to talk about death and planetary crisis.
Good, thanks very much, Elaine. So actually, let me kick off before I put my slides up with a conversation I had last night. I was talking to a friend who is in her late 60s, who is dying of a blood disorder. She is a retired palliative care physician, which is probably quite important. She knows that the median survival from her condition is about 19 months, and it's a year ago that she got her diagnosis. And at the moment, she's absolutely fine. She's cycling, she's hiking, she's having a very good life. In fact, she was describing how the prospect of her imminent death makes life that much more interesting and enjoyable. And we had a conversation about how she will die. And she's determined to die at home. And she's rejected aggressive treatment. She is being treated, but she's not having the most aggressive treatment. And one of her lines is that she would rather die of her disease than be killed by her doctors. And what's likely to happen is either that her hemoglobin will drop, and quite how long that will take between when it begins to drop and when she dies, she doesn't quite know. Or she might die quite suddenly of sepsis, or she might develop acute leukemia, which is one of the things that happens with this condition. She lives alone, but she's organized a support team. In fact, she has interviewed a death doula and lined up a death doula, and the death doula was really quite surprised and pleased to be invited so far in advance rather than by someone who was very close to death. And she's also interviewed 2 nurses who are going to support her. So she's sort of set up, she's ready. And in fact, she's enjoying life, as I said, greatly. In contrast, she told me about a colleague of hers who's actually 10 years older and has the same condition and didn't make any kind of preparation. And then suddenly he developed acute leukemia. He then had a gastric bleed. He had an operation. He then had a heart attack. He then had a stroke, and he died in intensive care. So I'm sure you don't need any kind of science to tell you which of those is the lower carbon death and which is the higher carbon death. It just seemed very apposite that I was having that conversation last night. So let me put my slides up now. Here we are. I hope that you can now, if I make them. So I hope you can see those. So I'm talking about death and the planetary crisis. And as Elaine said, I'm the chair of the UK Health Alliance, and I was also the co-chair of the Lancet Commission on the Value of Death. And I want to make 2 sort of observations before I get more practical. So one of the things we concluded on our commission was that really our very unhealthy relationship with death, and that seems quite a good way to describe our relationship, because of course dying is healthy, not dying in the long run is very unhealthy. But our unhealthy relationship with death, the planetary crisis, which we're talking about here, the pandemic and the other pandemics that will come, and antimicrobial resistance, all of these sort of flow from our delusion that we're masters of nature rather than very much part of nature and subject to all of its laws. The picture there is Krakatoa, which was a huge explosion that reminded us of that. And then this is, so here, I'm sure you've heard about the Alcor Life Extension Foundation. Those machines have bodies in them, people who have been frozen, waiting for when whatever they died of is cured, when they'll be resuscitated, their disease cured, and they'll go on living. Well, that's the idea. And the reality is that billions, literally billions, are being spent on the explicit pursuit of immortality or drastic life extension, much of it on the west coast of the US, where the high-tech people are rather horrified by the thought they're going to have to die, and so are quite willing to put lots of money into trying to extend life. But I find myself wondering how much of all medical research is an implicit pursuit of immortality. In preparation for our commission, I emailed a lot of leaders of research in this country saying, are you trying to cure all diseases? And if you are trying to cure all diseases, what do you think we're going to die of? They were quite politic about it. They came back to me and said, well, we are trying to cure all diseases, but we recognize that we won't cure all diseases. And what we hope is that people will be very healthy up until the day they die, which itself, I think, unfortunately, is a fantasy. We could talk more about that in the discussion. And then Freud, as I'm sure most of you know, said that we can't really imagine our own deaths. He said the unconscious of every one of us is convinced of his own immortality. They used sexist language back in those days. And I find myself wondering whether our relative comfort in living with death allows us to live in comfort with the fact that all life on our planet is threatened by the planetary crisis. Somehow it means we can go on day by day without suffering any kind of horrible nervous breakdown. Right, now to the crunch. So one of the things we established with the Lancet Commission is that about 10% of annual healthcare expenditure, and this was across lots of different health systems, in some it was more, some it was a bit less, is spent on the roughly 1% of people who die in that year. And of course, as probably many people on this call know, spend, cost, and carbon consumption are very closely related. And in fact, often when people are calculating carbon footprints, they're using cost because they don't have the actual data on carbon footprints. So that means that probably about 10% of the NHS carbon footprint is on care in the last year of life. And much of that is in the last month. There are quite good data on this from the NHS. So if you look at the last year of life, there are increases in GP consultations, increases in outpatient appointments, increases in attendances at A&E, and increases in emergency admissions. And most of the cost, as with the health system generally, is driven by hospital care. And you can see with this figure I've got here that there's this increase at the end because many people are dying in hospital when many people would prefer not to die there if they could find a way to die comfortably at home. And I think generally death in an acute hospital is not a good way to die. Now, most of you are probably familiar with the carbon footprint of the NHS. I simply wanted to make the point that it has multiple components. And if you think about that 10% figure I've suggested, that's quite a big chunk. I mean, the single biggest chunk is medicines and chemicals, mostly drugs, which is 20%. So it's lots of different things, and we need really to think about, and I think people have not tended to think about end-of-life care as an important part of the carbon footprint. But you can see here that it's at a level that really is important where we need to think about it. And is that money well spent? Well, if you think about spending 10% of the NHS budget, which itself is squeezing many other budgets in education and social care and the environment and housing and all sorts of other things, which actually in the end are more important for health than is health care, then it seems very odd to spend 10% on the 1% who die in that year. But I suppose if that money was very well spent and those people were dying very well, then perhaps as a society we would think that was justified. But that almost certainly isn't the case. This is a conclusion from the Lancet Commission. Healthcare has a role in the care of dying, but interventions at end of life are often excessive. They exclude contributions from families and friends. They increase suffering and consume resources that could otherwise be used to meet other needs. And here's some evidence on overtreatment that occurs at the end of life. This is taken from a substantial review published in the Lancet in 2017. It's about overtreatment generally, but this is the section on end-of-life care. So in many countries, evidence exists for the overuse of aggressive care for dying patients and simultaneous underuse of palliative care. Most people in the world would prefer to die at home, but about half die in hospital in higher income countries. It's not true, of course, in low income countries. Inappropriately aggressive cancer care near the end of life is a common problem. Overuse of aggressive end-of-life care in the UK includes futile insertion of PEGs, percutaneous endoscopic gastroscopy tubes, and administration of chemotherapy that hastens death, and we could add to excessive use of antibiotics at the end of life, ineffective intensive care unit treatment at the end of life. And they included a study from Korea that found that most patients with terminal cancer receive futile intravenous nutrition during the last week of life, with most of those not having any discussions on palliation. So, as Elaine said at the beginning, the main recommendation of the Lancet Commission was that we need to rebalance death and dying from belonging to the health system, as it does now primarily, to belonging to families and the community, with health professionals are still going to be important, but as supporters, not leaders. And this picture is important because it comes from Kerala, where they have succeeded in achieving exactly what I've described there. They still have deficiencies, all systems do, but they've made a lot of progress. And in the Lancet Commission, we imagined a realistic utopia. This is an idea, realistic utopia, introduced by the philosopher John Rawls, and Richard Horton, the editor of the Lancet, encouraged us to do this. So with our utopia, social determinants of death, dying, and grieving are tackled. The social determinants, just as we've come to all know how important they are in health, they're also important in death, dying, and grieving. Dying is understood to be a relational and spiritual process rather than a physiological medical event, which is how so many people have come to think about it. There are networks of care to lead support for people dying, caring, and grieving. That happens in Kerala. In this country, we have compassionate neighborhoods, compassionate communities, compassionate cities, which I think have not gone as far as they have in Kerala, but it's certainly a start. Conversations and stories about everyday death, dying, and grieving become common. We talk a lot about death and dying. And death is recognized as having value. And we define how death has value in the Commission. But the easiest way, I always think, is that if we didn't have death, then every birth would be a tragedy. And in our overpopulated world, we're on the edge of that already. And I would like to add to our realistic utopia that we aim to get end of life care to carbon net zero, as we must everything if we're going to keep the planet healthy. And one of the other main conclusions of the Commission was that we have to think in terms of systems. Unfortunately, systems are very complicated. But if we try to make rather sort of simple interventions to improve things, they can go badly wrong and have unintended consequences. And we write in the report about the Liverpool Care Pathway, which unfortunately, there was good intentions behind it, but its overall effect was not good. And we concluded that rebalancing death and dying will depend on changes across death systems. The many interrelated social, cultural, economic, religious, and political factors that determine how death, dying, and bereavement are understood, experienced, and managed. And changing systems, which we increasingly recognize is important for the planetary crisis. It's important for non-communicable disease. It's important for obesity. These things all come about through complicated systems, but that's what we need to do. And so I'm giving you a take-home message. I've got 2 further slides. So my main message I want to get across here is that to recognize that end-of-life care has a substantial carbon footprint, and that it's highly likely that the footprint can be reduced dramatically with improvements in death and dying. So I think there is great opportunity here. So what now? Well, we need to explore ways of implementing the recommendations of the Lancet Commission on the value of death. And you can get the report for free on the Lancet website. I would urge you, if it's all possible, to read the whole report. I think simply reading the executive summary is not enough. We need to work with communities, and we have plans to do that. We need more research. We need advocacy. Then I think we also need to measure the carbon footprint of current pathways at the end of life, and rather with continuous quality improvement, experiment with ways of reducing it. But I think we need to do that beyond just the health system, because we're not going to have the effects we want if we think about it entirely within the health system or even within palliative care. We need to increase the role of communities. And I do wonder whether we should establish a citizen-led transdisciplinary commission on getting end-of-life care to net zero. And I wonder whether that isn't a job that we, the UK Health Alliance, could take on. We already have a commission on net zero surgery, recognizing that it involves many different disciplines, many different specialties, and we perhaps could do something the same here. And I thought I would end with something you can do today. So I hope all of you have got a will. You should have, and you should write into your will, how do you want to dispose of your body? And these are data that came from a Dutch study, which we include in the report. So the cost to compensate for different ways of disposing of a body. This was a way to be able to compare different methods. And of course, in the end, you can never compensate, that we have to be very wary about offsetting and sequestering. But nevertheless, it gives you a sense of the size of the carbon footprint of different ways of disposing of bodies. So they concluded that for a traditional burial, it was 64 euros, for cremation 48, but alkaline hydrolysis, which is available in the US and is becoming available here, it's only 3 euros. But probably much better will be actually to compost bodies, and there are people working on composting bodies, so then we can be fed back into nature and can be very productive. So thank you very much for listening to me, and I hope I've set the scene to listen to Max and Jane.
Thank you. Thanks, Richard. Being fed back into nature is a nice way to finish. Thank you for that. So we heard a bit about the carbon footprint of the medical interventions that happen at the end of life. And the other part of that is palliative care. So I'm going to hand over now to Max Watson, who is the director of Project ECHO with Hospice UK. And Max is also a palliative medicine consultant. So over to you, Max, for your presentation. Thank you.
Great. Can you see the slides okay, Elaine?
Yes, we can.
Brilliant. Thank you very much indeed for this opportunity. I feel a little bit of an imposter, realizing that other people know so many more things than I do in this area. I've been trying with Richard to do a bit of writing over the summer, but I find it really difficult. I'm conscious of being paralyzed internally, as I kind of come to terms with a whole range of issues which relate to this topic. Extractive economic basis for climate injustice, how this area, I see my good friend Raj Gopal there, and it makes me cringe when I think of what my generation has done and has been responsible for. I find that paralyzing. The guilt, the emotional weariness, the environmental responsibilities exposed, and then the kind of the hidden internal paralyzer of, oh, I'm just too busy doing important stuff. And all this time, the external paralyzers, we know all about them. We live with them, the Brexits, the pandemic, what's been happening in the Ukraine and in other conflict zones across the world, economic inflation, that there are now food banks across the NHS for NHS staff. The leadership vacuum in so many areas, workforce pressures, hospice, all these paralyzers, which can lead us to the hand-wringing of inactivity, and it's produced my inactivity in getting this editorial written. And so, got to bring it down. Why is this important? Why do I need to get off my fence of uncertainties? The practical reasons to ensure that the health service is able to continue to provide healthcare into the future, given the financial, social, and environmental constraints that we're aware of, and the ethical, as Richard has been saying, to protect the health of current and future generations across our whole world by minimizing the health service's contribution to climate change and its ongoing impact on the determinants of health. This question from Jonas Salk, the creator of the polio vaccine, has been weighing heavy on me of late. Are we being good ancestors? And the answer is not a good one. More personally, it's becoming a grandfather and having to look at my grandson and our world and the world that he will be inheriting, to which I have contributed. And in the light of this, as we think of the potential of what is happening, that we and the future palliateurs across our planet could be tasked with the palliation of humanity's grappling with the diseases caused by climate destruction. So I want to suggest six things that we could really kind of commit to and make a direction on. And this is what I've kind of come up with. Palliative care, number one, palliative care showing up to the climate emergency. I still am active in care, and I see myself and I see my colleagues every day showing up to patients, showing up, being palliative doctors, showing up, being there with others. And by showing up, I mean, it means bringing our heart and our mind into the suffering of the climate emergency. We do this with patients. We need to do it in relation to the climate emergency. Showing up now, not the hand-wringing, but showing up now, showing up in the areas where we can. Don't get paralyzed by not showing up in areas where we don't have access to. Showing up with the people with whom we can show up, and commitment to learning together as we show up. We don't know what we don't know, but if we commit to the journey, we will learn on the way together. Number two, learn from others. I've been so impressed with what people like Elaine have been doing and the Centre for Sustainable Healthcare. There is a lot of fantastic stuff which has been done. There's the Palliative Care Sustainability Net on that website. Really good beginnings. There's what the Royal College of Psychiatrists have done with their green agenda, the College of GPs. What are we as the palliative care body doing? What is our connection? And we don't have to begin from square one. We can learn from others and just apply it within our settings, such as Francis Mortimer's Centre for Sustainable Healthcare Principles of Sustainable Clinical Practice. How do we apply that within palliative care? Patient empowerment and self-care, learning service delivery, prevention, low carbon alternatives, taking the learning, applying it within our specific context. Within this, I was really struck by value-based healthcare. Value-based healthcare, yes, we want really good outcomes for our patients and the populations that we serve, but we have also now got to take account of the triple bottom line of the environmental, the social, and the financial impacts. We cannot work in isolation of our world, and true value takes account of this really important equation. Number three, harnessing the current appetite to act. I've been involved over the last few years with communities of practice right across the hospice palliative care community. And there are two big issues which have been highlighted across the networks, which come back again and again and again as things that people really want to do. We, as a population of palliative professionals, we want to improve on EDI. We want to improve on our understanding, on our relationships, on our works with people from a variety of ethnic backgrounds to become much more inclusive, to make that shift from talking about people as hard to reach to realizing just how exclusionary our services can be. And number two, it's being, how can we face up to our climate responsibilities? And this in the face of all the challenges of COVID. So we need to harvest the current appetite to act and provide people with the answer to this question. If only we knew what to do. People are willing to do it. There's an appetite out there. Number four, as Richard has been saying, across the NHS, really good work has been taking place, gathering data. We need to gather baseline data from hospice and palliative care services of what our carbon footprint is. If we haven't got that data, we can't see how we're improving or how we're disimproving. And at the beginning, it doesn't have to be really dense data. We can grow the data, but that commitment to gather data, which we can then use to improve our learning, to improve our development, to improve our commitment to this journey. We need to start gathering good data. Number five, and here I express my total commitment to ECHO, which stands for Extension of Community Health Outcomes, which is really a commitment not to an IT system or not to a particular program. It's a commitment to a way of working collaboratively online. Everyone a teacher, everyone a learner, moving from hierarchies of knowledge and power to networked approach. During COVID, we began a clinical ECHO across the hospice and palliative care sector because we didn't know what we didn't know, and we had to work very quickly together to share what was working, what wasn't working, what the evidence was this week, what the response was, so that together we could face the challenge of COVID. I see this movement as being identical to what we need as a community to do as we face the challenges within palliative care of climate change. To learn from each other. What are you doing? What are you doing? Have you done this? Has that worked for you? We didn't find it. And build and work collaboratively together, supporting and connecting the green champions. And there are many of them, as the numbers presenting and are coming today has shown, across the hospice and palliative care sector. Can we connect them up so that we rapidly gather their knowledge and their experience together, using Myron's maxims, because we know when we work collaboratively together, people own what they help create, and so quicker and better outcomes result. We know that real change happens in real work, so it's in the real experience of facing the challenges within hospices and within palliative care settings that we will produce the real change, and that the people who do the work do the change. That's what really makes the difference, getting beyond my paralysis into actually doing stuff, and then connecting the system to more of itself. And so we have this, if you like, quality improvement loop, where we support and connect the green champions who work collaboratively together to share what worked for us across the wider hospice and palliative care sector, who then have an answer to their question, if only we knew what to do. And we try that, and we look at it again, and we generate more solutions as together we really engage and develop and move forward with the energy which is so important for this area. And then finally, number 6 step, collaborating with others. Collaborating with others. So learning from others about the use of inhalers, learning from others about use of electronic vehicles, learning from others about how we can change our use of medications. There's a lot of work going on. We don't have to reinvent the wheel. Collaborate with others. But we also, and Richard has highlighted that in his talk at the beginning, we also have some unique contributions to reducing global warming to share with others. And what are we talking about here? As Richard has said, the most unsustainable healthcare is care which brings detriment to patients and is futile. 10% of the NHS carbon footprint. And Richard has outlined what that care looks like. The most powerful thing that we can do is to reduce this futile, inappropriate healthcare, which often causes increased distress to patients and families. And our tools in regard to advanced care planning, yes, really helpful. How do we use that tool in that end? Then deprescribing. I deprescribe every day in my palliative care setting, but there's much more that needs to be done. During COVID, we reused medicines that went out to people's houses because we were worried about not having enough. But we've gone back. There is much that needs to be done about reusing medications, to reevaluating the risks of reusing medication in terms of the risks to the planet, etc. There's the value, all the things that we learned through virtual services and compassionate communities, which have developed so much during the COVID time. Vital stuff. Affirmation that dying is a human event, not a medical one. And the responsibilities and the engagement that is taking place within palliative care, with schools and with others, sharing this truth. And then the conversations. We're good in palliative care, by and large, at conversations, maybe better than other specialties. That's something to share, listening to what patients are really saying and promoting engagement rather than default activity. Sometimes it feels that it's easier to put up a line than it is to have a conversation. And promoting true value in healthcare delivery, remembering that equation and this phrase, sometimes as physicians of value, we need to do nothing, but nothing really well. So my pathway, show up now, learn from others, harness the goodwill that's there by providing clear ways forward, get the data, support the champions in a quality improvement type manner, and collaborate with others. Thanks very much, Elaine. I'll try and stop sharing.
Thank you so much, Max. And there are 6 really, really straightforward but really meaningful actions that I think we can all take. And I'll just mention, you may have seen while you're getting your unshare happening, we can still see, oh, there it's gone. Last week, on Thursday last week, we organised a Ride for Their Lives, which had a number of the presidents and chairs and senior people from a lot of the member organisations from the UK Health Alliance. And that message of coming together and collaborating and the power of working together and learning from each other really came through. And it's such a strong message that that again, Max, you've highlighted there as well. So I think it's so relevant to the work that we're doing. I'm going to hand over to Jane now, who has got a fascinating title for her talk, A Good Surgical Death. So over to you, Jane.
Thank you, Elaine. So I'm going to talk about what I think a good surgical death is, and how, if we can do more good surgical deaths, how that will have an impact on our carbon footprint. And I'm currently a professor of surgery at Bristol University, but for 30 years I did work in the NHS, and my clinical area of interest was esophageal cancer, gullet cancer. And for 30 years I did esophagectomy. So an esophagectomy is one of the most mortal and morbid elective surgical procedures. And we've tried to make it better and better over the years. But when I thought back about deaths following a esophagectomy, I don't think I saw very many good surgical deaths, I'm afraid. And there are two groups of patients that stick in my mind around that. So one is that there's a group of patients who we did an esophagectomy on, and they went home after 10 days or so, and then they basically felt awful. They never really recovered from their operation. They felt tired, in pain, they felt sick, exhausted. And what happened then was we'd investigate them and they would have recurrent disease and they would die within 12 months of that operation. So 20% of patients who have an esophagectomy to this day die within 12 months of surgery. And I don't think, we saw lots of decisional regret. You know, I would not call that a good surgical death. And the other group of patients that I don't think we got it right on were patients who we would also do an esophagectomy on, and then it went wrong, technically went wrong, and then we'd take them back to theatre, we'd try and fix it, we'd put them on ITU for weeks, and we'd reoperate and re-intervene. And despite all that, they would die. And there was never had been with those patients a conversation at the outset about how far we should go with them. And so they also did not experience a good surgical death. So the question is, for today, is what is a good surgical death, and how might that, if we can get better surgical deaths, how might that make a difference to the carbon footprint? And hopefully you can see my slides now. And I was involved in the Lancet Commission on the Value of Death. I was a commissioner at the outset, which was a real privilege. So the thing is, I think a good surgical death differs from a good medical death. And this is the key difference, is that when you choose to have an operation and you have that operation, there's no going back. It's a one-off thing, and usually the side effects all immediately start from the day you have your operation. You can't reverse it. Whereas with drug treatment, not always, but with most drug treatments, should you then experience unpleasant side effects or should you experience little benefit, you can decide to discontinue them. Whereas surgery, once you've had the operation, you're stuck with the consequences. Another difference about surgery is that an awful lot of surgical procedures, particularly at the end of life, are not evidence-based. So there really is uncertainty about whether they're going to help. And alongside that, there's this sort of slightly optimistic view that's held amongst everyone, I think, that they have unrealistic expectations of what surgery can actually achieve. And to some extent, to be a surgeon, you have to believe in what you're doing. And so there's a tendency to be over-optimistic about what surgery can offer at the end of life. And if that's what's happening with surgery, then I think what needs to really be thought about to have a good surgical death is actually about having a good surgical decision. So to me, a good surgical death is a good shared decision about whether or not to undergo surgery at the end of life. And if we can get those decisions right, then we can help benefit patients to make decisions that meet their values, and that will have an impact on the carbon footprint. So some patients with the appropriate support may still decide to undergo surgery, others will decline. And when we get into that situation about you're not quite sure how far to go post-operatively with repeat operations, then there will have been advanced discussions about that. So good decisions can be made at that point. But to me, it's all about that decision making. And at the moment, it's really difficult to know what the quality of surgical decision making is at the end of life. We just don't really know. It's an area there's not much published about. What we do know is that surgery and invasive procedures are common at the end of life, as we've already heard. This study showed that of elderly people in the States, a third of them had a surgical procedure in the last year of their life, and there's other data showing that people that undergo high-risk surgery are likely to die, a 25% chance of dying within 90 days. And in the UK, of all surgical inpatients, 20% of them have had surgery in the last year of life. So we know that lots is going on, but we don't really know what the quality of that decision-making is around it. And we've already looked at this paper that Richard talked about. We do know that worldwide there's no views in medical services. But one of the challenges with surgery and thinking about how to make those decisions better is that surgeons themselves, we like to operate. And, you know, although we know it might not benefit patients, and although it does have costs to the NHS and a carbon footprint, there is, and we've seen this thing at the end of life with this huge increase with the costs in the last 10% of time. We do know surgeons like operating, and that's a problem, I think, because we do like fixing things, we like reshaping and remaking things, you know, we do like to intervene, and when we like to do, basically, and surgeons are not renowned for being good communicators. And, you know, there is a tendency to do and think occasionally rather than think and then do. And so I think this is the thing that needs to shift with surgery at the end of life. And it has been said that a good surgeon knows how to operate, a better one knows when to operate, but the best one knows when not to operate. And I think this actually just is a typical sort of slightly old-fashioned dogma, because it's really paternalistic. It's sort of the surgeon telling the patient what's needed. And I really think what needs to happen is that we have a good surgeon knows how to operate, a better one can know when to recommend it, but the best one knows how to support a patient to reach a decision, their decision that takes into account their values about surgery. So I do think it comes back to the decision making, like so many things in life. So how do we make that happen is the question. So imagination is more important than knowledge. So we do need to reimagine a change in surgeons and surgical practice. You know, as the Lancet Commission is recommending, we need to really think how this could look differently. And if we can get ourselves into that place, we can make it happen. In the UK, there's nice guidance that thoroughly supports shared decision making in every aspect of medicine, surgery, medicine, primary care, secondary care. It hasn't sorted out the whole process in the emergency setting yet, but it strongly recommends this. And what NICE says is that shared decision making, which is what we're talking about, has inherent social value, it's ethical, patients find it meaningful. We find that patients who've had a shared decision do have more realistic treatment expectations, they're more likely to adhere to treatment plans, they have less decisional regret. And it is associated with lower health services utilisation. So how do we really get this whole vision into a realistic utopia for surgeons? Now, these 5 things that we've already looked at, when you look at them all and think about how on earth are they going to be implemented in a surgical context, I think it really is all about changing the culture of surgery, and that can be done in multiple different ways. And particularly around surgical training. But in many ways, it's possibly easier to implement the Lancet Commission recommendations within a surgical specialty than perhaps across the whole of healthcare, because you're dealing with a pre-specified group of people, with surgeons mainly, and then the systems within which they work. But I think we need to really think about interventions to help surgeons have those conversations at the end of life. Now, it is recommended, the Royal College of Surgeons, their website does recommend that surgeons that have, you know, do pay attention to communication. And in the States, they have training for surgeons in those how to have those consultations. And although it's recommended, as I said, we just don't really know whether it's done well. And we do see an awful lot of procedures being done at the end of life. So there's no doubt, and my senses and my experiences, that this is something that needs to happen. And how do we get surgeons to do this? Now, in the Lancet Commission, Atwal Gawande, who's this famous surgeon and author, was quoted, and he recommends that surgeons do have these difficult/essential conversations. And he said that surgeons just need to ask patients these 5 questions, and then he listed 6, but anyway, here they are. And these sort of questions that are on the slide, I think they're actually very difficult to direct those questions at patients, and very few patients will have actually already thought through their answers, and it's hard to suddenly say, what outcomes are acceptable to you. I think these are difficult things to answer, and I think much more thought needs to go into how surgeons have those conversations and what really needs to be discussed, and almost more consensus views are needed about what actually should those conversations look like. And what we've been doing in Bristol is developing interventions to improve informed consent for surgery. And what we call these are core information sets. And a core information set is a minimal set of things to be discussed in a consultation in which a surgical procedure is discussed. Now, when we define what's core, which we do in a very predefined way, it's so important that the people that make those decisions, there's an equal number of patients as there are as health professionals. So our core information sets represent things that matter to patients and things that matter to surgeons and maybe specialist nurses, depending on the situation. And those core information conversations would be using that set as a baseline, just as a baseline, as a starting point, to allow core things that have been already prioritised by patients and healthcare professionals to be discussed. So rather than a direct question to patients, these would automatically be raised. And they would allow the patients, what we're finding is they allow a sort of the patient an opportunity to reflect, they allow the patient an opportunity to reconsider, to take stock and to ask maybe for more information. They can help them deliberate and catalyse more questions. And we've developed core information sets for those areas listed there and a generic one around innovative procedures. But at the moment, there is no such thing as a core information set for helping surgeons and patients make those important decisions at the end of life, whether or not to have an invasive procedure. And that's what I think is needed. And the way we do it is we really look not just at the literature and what's published, but we really listen and look into the black box of the consultations of what goes on. So we audio record conversations between surgeons and patients when they really are sharing those difficult decisions. And from those, we distill things that are then discussed and then prioritize using Delphi methods to really agree what's core. And in the esophageal cancer core information set, for example, one of the core pieces of information is to give patients information about the operative risks and the mortality, the long-term survival, which is not something surgeons typically do. But patients wanted to know that. So this is something we think could really help. So we think that would help. And the core information set wouldn't just be a simple intervention, it's a complex intervention, and it would need to be infiltrated throughout the complexity and the chaos of the NHS, taking into account all the systems that would need to allow it to happen. So in summary, so surgery at the end of life, is not always good for patients. It has uncertain benefit. It definitely has substantial carbon footprint. And I think that a good surgical death is one in which a good decision is made whether or not to undergo surgery. And those decisions can be influenced by better shared decision-making between surgeons and patients. But there needs to be a culture change. Surgeons need tools such as core information sets to be able to do that well. And they need time and they need training. There needs to be more research that compares surgery with conservative treatment, looks at patient outcomes and measures the carbon footprint. There needs to be leadership and training. But I think that's all completely possible. We can reimagine that future over the next 5 to 10 years. And that's certainly work that we've been hoping to do in Bristol. And I just wanted to acknowledge some of the people that have worked around this area with me over the last few years. Thank you for listening.
Thank you, Jane. That was fascinating. And certainly the decision-making and those conversations has triggered a lot of comments in the chat of different people's experiences as well. So I'm just going to go to the chat and I'm going to pick up on a couple of those questions in a minute. But first of all, there's a question from Artie Bansal about the work in Kerala. Is it possible, Richard, to expand a bit more on that? What worked in Kerala?
Actually, I've got a better suggestion because I saw on the call is Raj, who's one of the chair of Pallium, which runs the there you see him waving there. So instead of hearing a second-hand opinion, why don't you hear it from the horse's mouth? So Raj, maybe you'd like to tell Artie about Kerala.
Richard, thank you very much, and thanks for your permission, Chair. in Kerala, we make happen something that the Asthana Declaration asked us to do, to give partnership, not only partnership, but also control over healthcare to the community. In part, we develop or facilitate compassionate communities so that the local volunteers work with a palliative care team to not only for dying, but for living with illness. Living with illness and dying well, they provide support. By no means is it perfect. By no means is it reached good enough. But they actually make happen something that the Lancet Commission advised. They bring death back to life. They would know from elders how people die, and they would hold the hands of the family and help with bereavement also. But they certainly need the help of healthcare professionals. So it's a collaborative work. Thank you.
I would simply add, you can read a lot about it in the report, but Raj has given a splendid summary.
Thank you. And thank you so much for joining us and for doing that on the spot as well. It's very much appreciated. In terms of the conversation, it's quite interesting. So looking at the chat, there's two different sides that have been presented. So on the one hand, a story where unnecessary interventions and suffering have happened because medical professionals have avoided a conversation about prognosis. But then on the other side of that, we've retired GP Terry Kemple has said that within his practice as a GP, he's tried to have conversations without patients early on before they had any life-limiting illness. But people are reluctant to talk about it, and it gets easier to talk about it the closer to death people become. So how do we balance those two different aspects up? Don't know, Richard or Jane, do you want to come in?
Why don't Jane go first, and then I'll add something.
It's more than a medical. It's not just medicine's responsibility. Would be my answer. This needs to be tackled from other key stakeholders, even churches and the spiritual community. I think the whole of society is struggling to talk about death, not just doctors. But for doctors to do it, I think it's slightly easier, and that we know where we need to do that. We need to train them. We need to raise the issues, show them the data. But I think it's a much wider problem.
Yes, I was in a way going to say the same thing. That's why I put up that horrible diagram of systems, that I think we've realized that simply by trying to change things within the health system is not enough. There's got to be broader changes. And there are a lot of these things going on. So there are, as people know, there are death cafes. There's a death awareness programs both in Scotland and in England and in other countries. I spent 3 days once at a death festival on the South Bank in the Arts Centre in London. And it was a great experiment, really, that was set up by people who'd had bad experiences around end of life. And I think you find if you go out and have conversations with people, you'll find that almost everybody's got a story to tell of bad experiences and rather fewer stories of good experiences. And this festival was set up with the idea that there didn't really seem to be a space to talk about these things anymore. And it was quite a risk, because it was a big, complex, expensive festival, and it was quite possible that nobody would turn up. I mean, when I talk to people about I'm on my way to a death festival, people used to sort of snigger and laugh and think, well, that sounds a bit ridiculous. Why would you go to a death festival? But actually, it was packed. You could hardly get into many of the seminars. There seemed to be a real appetite to talk about it. One other thing I would mention is that, I mean, one of the people on the commission was Scott Murray, who I think maybe the world's only professor of primary palliative care, and he's now an emeritus professor, and certainly introduced in Scotland. He talks about it as anticipatory planning, anticipatory care, rather than some of the other phrases that are used. And they have had a lot of success in Scotland with encouraging these conversations. So you're not in the sort of desperate position of having truncated conversations at the very end of life. But I completely agree with Jane. It is a lot of it is about these conversations, and that's why one of the things on our realistic utopia is that we live in a world where there are many more such conversations. And I think, I mean, my children, they sometimes bang the table and say, well, it's taken you 30 seconds to start having a conversation about death. Why so slow this time? And I think you find there's quite an appetite, just like there is for talking about birth, there is for talking about death and dying.
Thank you. I'm going to pick up another, just so you just mentioned there, anticipatory care, because that's certainly come up in the chat quite a bit as well. And I think it was more about prescribing as well. I appreciate that Max has unfortunately had to leave us. He had another meeting that he had to go to. But there's a question there from Don Brown. Often there's pressure on GPs by district nurses to prescribe 3 to 4 days worth of all meds for anticipatory care. I would be interested to know what others think is a reasonable amount, and whether we should limit the range of meds we have in what is essentially a starter pack that may or not be used. So it's a very specific question. I don't know if there's anybody else on the call, or if Jane or Richard want to come in on that issue either.
One brief thing I'll say, I mean, I experienced this not because as a physician, but because my mother died recently, and they prescribed, and they write a prescription that says if and when she needs these drugs, they'll be available, which obviously was a good thing to do. But what I was rather taken aback to discover is, I mean, she didn't use most of them, and evidently they're then just discarded, which seems to make no sense whatsoever. So I think there is an issue there, but there probably are palliative care people on the call who'll be able to answer it much better than me. Kate Crossland there, can she help us?
Hello, I can try and help. My sound's been a bit patchy, so I hope you can hear me. And I can see my colleague Angela Hayes is on the call as well. So I'm part of the Palliative Care Sustainability Network. We've actually got a meeting today at 4:30. So very timely, and we've been doing some work on anticipatory prescribing. We've just done a very rough carbon footprint estimate. So for one patient, it's around 12 kilograms of CO2 equivalent. So driving about 50-60 kilometers in a car just for one patient. Yeah, I see some raised eyebrows. That's the reaction that you get. So what we're trying to do in our network is really a bit like Max was talking about, start that conversation, inspire some thoughts. The Centre for Sustainable Healthcare have some great resources around sustainable quality improvement projects. So looking within our own teams about how we prescribe, what we prescribe. St Christopher's have done a fantastic project, which I'm hoping they are going to publish, where they looked at their anticipated prescribing for cost reasons rather than carbon reasons, but it's very closely aligned. And now less commonly prescribe all 4 drugs. So they might just give pain relief and something for agitation, but not always an antiemetic or an anti-secretory. So halving their costs and halving their carbon. And then there's also lots of work to think about what are our out of hours practices, because one of the reasons that we put those drugs in the home in anticipation is because they're really hard to get hold of if you're in an out of hours situation. So can we turn that around and look at what the processes are so that we feel a little bit more comfortable that we could get these things if we need them. So lots of discussions happening about that. So very much a hot topic at the moment.
And Kate, could I ask you, if they're not used, what happens to those drugs?
They are incinerated. So that that carbon footprint doesn't take into account their incineration, although it's quite a small amount. And I heard at a pharmacy sustainability talk not so long ago that there's some work happening there with having sensors on medication packets, because if you could return them to the pharmacy with, if you like, a guarantee that they've been stored within an agreed temperature range, you could then start to talk about reusing them. So there are things happening there. Yeah. All happening, hopefully.
Thank you. Thanks so much, Kate. Appreciate that. There's just one other question I'm going to pick up in the chat, and it's from a retired GP, and Stephen C. Saying the impression is that time speaking with patients is in terribly short supply. Can people like me volunteer to help with those discussions? So is there a role more broadly for other healthcare professionals who may be not practicing anymore to open up the conversations? I know the onus is on everyone to be more open, is the message that's coming through, but is there a role for maybe retired healthcare professionals in this? Richard or Jane?
I think yes. I mean, one of the Lancet Commission recommendations is to increase the dialogue with everyone, and certainly in thinking about surgical practice, that having people that we need to have the whole thing talked about more, and having people with more time or more experience would be definitely helpful.
I mean, I would simply add, I think one of the challenges we're presenting through the Lancet Commission is to think, beyond healthcare. I think there is a tendency to think, because that's what we're used to and where we feel comfortable, to think most of the time within healthcare. And in fact, I'd say in some ways it's got even worse, because one of the things I worry about with the creation of palliative care as a specialty is that it allows a lot of other health professionals to think, oh my goodness, this patient is near the end of life, transfer them over to palliative care, and it's nothing to do with me anymore. And one of the things we very much advocate in the commission is that actually all health professionals should be comfortable with dealing with death and dying, which is how it once was, and that beyond that, the many people in the community should feel much more comfortable with it. And there, as in Kerala, and other examples of where this has happened. So I think we need to sort of think beyond the health system. I think that's one of the things that's key, and to think in this sort of systems way. I don't know whether Raj wants to add something.
No, not really, but the suggestion about retired healthcare professionals coming into the field brings up an important point. Yes, certainly, but as human beings, not only as professionals. It's everybody's business. It's not only for professionals. We need to bring death back into society and make sure death and dying need to become everybody's business. It touches everyone. Why not? But as Aarti says, maybe the term death cafe is too frightening for people who are now scared stiff about it. And maybe a more friendly term can be used. But how long will we avoid the term death?
I'd also add there's something rather defeating about the idea that, we don't have time to have a conversation. I mean, if you think of what Jane has just presented, so if you avoid the conversation, maybe they're going to end up with umpteen operations and a horrible experience. So actually we should see conversations as the very heart of what we're doing, not as a sort of something on the side when you're not, instead of prescribing or operating or doing whatever, the conversation is the most important bit of all of this.
And so just to, we haven't got any more questions. So, I mean, ultimately, the message is we're all human beings. We need to talk about it. We need to value death and be more open about it. And the onus is on everybody to do that. I am going to close the session there. Thank you so much again to our panelists. It's been really, really fascinating. So thank you, Richard. Thank you, Jane. Thank you, Max. And thanks to everyone as well for joining us today. It's been a really, really good discussion and great conversation on the chat. And thanks as well to everyone who's shared the links on the chat as well. Thank you.